Welcome to AETCM, the emergency medicine channel. A 41-year-old male was brought to ER with complaints of sluggish response post voluntary blood donation. On initial 10-second assessment, airway was patent. Patient was replying but slowly. Breathing wise, respiratory rate was 16 per minute with saturation of 98% room air. Circulation, BP was 100/70 with a heart rate of 138. Cardiac monitor was connected at this moment. Pulse was felt, pulse was irregular. Disability wise, GCS was E3, V5, M6, pupils bilaterally equally reactive. Exposure wise, patient was afebrile. We took an initial point of care VBG and an ECG. ECG was showing heart rate of 138 with narrow QRS complexes with absent P waves and irregular RR intervals. VBG wise, pH was 7.43 with PCO2 of 35, bicarb of 23.1, potassium of 3.3, sodium 142, calcium 1.09, and a lactate of 4.6.
Okay.
We had also, creatinine was 1, and at this time we had also asked for a point of care troponin. Then we started the patient on 1 pint IV bolus fluid. Coming to sample history, 41-year-old male went for voluntary blood donation around 1.5 hours prior to presenting to ER. Prior to donation, his vitals were BP of 120/80, pulse rate of 74 per minute, and a saturation of 98% room air. After blood collection of 450 ml of whole blood, patient developed sluggish response and involuntary micturition. But there was no abnormal jerky movement or any deviation of face or uprolling of eyes or any chest pain. Repeat BP of the patient was taken. It was showing 90/60. 1 pint bolus was given in the lab itself, and patient was shifted to ER. On arrival to ER, patient's BP was 100/70. Allergic history, he was not allergic to any known substances. Medication history, no known comorbidities. He is not on any regular medications, and he has history of regular blood donations. Last meal was consumed 3 hours back. After being shifted to ER, we got the BP of 100/70 with a lactate of 4.6. Heart rate was 138. ECG showing no P wave with the irregular pulse wave, irregular RR intervals, and tropi of 577. So we started the patient on tablet ecospirin 325 milligram and atorvastatin 40 milligram stat, and also we gave Clexane 0.6 ml to the patient. Then we reassessed the BP after 20 minutes. Patient's BP was 80/60. So at this point, we have a provisional diagnosis of patient, the ECG showing features of AF. And since his again BP fell down, it was an unstable AF at this point. So we had already informed cardiology beforehand, and a screening echo was also done. Since unstable AF, we decided to cardiovert the patient. So consent was taken, and for sedation, we gave ketamine 50 mg and fentanyl 30 mg stat. And we went ahead.
Only one drug that you should not have given for procedure sedation, and you are given for this patient. Continue.
And the patient was cardioverted with 100 joules.
Okay, so let's break it here. Okay, so we have a patient with possible syncope. We can label it as syncope, right? So he had a blood donation, he had a syncope. So postal hypotension, syncope, and he has come to the ER. So you have given him the fluid boluses, but still the heart rate was on the higher side. So he has developed an atrial fibrillation. So what will you name this atrial fibrillation? What will you name this atrial fibrillation? Because here I am very confident to say that there was no previous history of atrial fibrillation because he is a regular blood donor. So few negative things, what risk factors we can remove from here is smoking, alcohol consumption, all those things which are the major risk factors for a blood for an atrial fibrillation we can remove, because when they are regularly donating blood, they will not be allowed to donate when they are doing these things. So long comorbidities, everything is removed. But structural heart disease underlying, they don't do an routinely echo, but every time they do an pulse vitals evaluation, there was never an atrial fibrillation for him. So it's the first time that he has been detected as a atrial fibrillation. So what are the definitions of atrial fibrillations? So it is the first detect atrial fibrillation. So that is the technical definition that you can put it for this patient. So you have atrial fibrillation, then you have clinical atrial fibrillation, then we have subclinical atrial fibrillation. Now, what is subclinical atrial fibrillation?
That is detected incidentally on some other monitoring or some
See,
device.
right now everyone will have a smartwatch. You get an Apple Watch and you have all the facilities. So it will detect that if you are having a subclinical atrial fibrillation, and it will detect, and you will recognize the patient is having atrial fibrillation. Without any reason, you might be able to see an atrial fibrillation. So that is subclinical. You don't have any clinical features. Clinical AF, what we have seen is a clinical AF, but this is the first time that he is having atrial fibrillation. Then what is paroxysmal AF?
So, which occurs suddenly and resolves within 7 days.
Within 7 days.
24 hours.
Then what is persistent AF?
It will be persisting more than 7 days.
More than 7 days, maybe more than 1 year duration.
Could continue.
Permanent AF, lifelong. More than 1 year it is there. So these are the accepted definition for atrial fibrillation. So clinically, atrial fibrillation means you have got an irregular RR interval. There is an atrial dysrhythmia. Whenever you get an atrial fibrillation, the first thing that you need to keep in your mind, some problem with the atria. Somewhere there is an issue in the atria. Either can be right atria or left atria, but most commonly in the left atria is what we see regularly. Chronic hypertension, mitral valve diseases, creating left atrial myxoma. That is a common reason. Hypertension creating left ventricular hypertrophy and left atrial enlargement. So that is the most common reasons that you see. So structural abnormality is one thing, but whenever you develop a new onset arrhythmia, another thing is an myocardial infarction. So ACS is one of the other differential. Even AF, when we say AF, a new onset AF can be part of ACS. Yes, it can be part of ACS also. But these are the different terminologies that you need to remember. So here we have put it's a first detect atrial fibrillation. So why he could have developed an atrial fibrillation, we don't know. We don't have any reason. What are the common risk factors for atrial fibrillation? Anything that I have missed, you can add on. What are the other risk factors?
Usually, if patient is having any ischemic heart disease, he can develop. If any hypertensive heart disease, he can have. Then congenital heart disease, ASD is there. Then any cardiomyopathy, any myocarditis, it could be there. Other than that, if patient is having COPD, if there is history of binge alcohol drinking, if thyrotoxicosis features are there, pulmonary embolism,
obesity, less physical activity, then sedentary lifestyle. So these are all risk factors. When you name anything, one of them will be sleep deprivation. That is one of the, we think sleep deprivation is not, that is one of the risk factors that has been identified as one of the reason for your atrial fibrillation. So there are many risk factors, but in general, we don't see any risk factors in him. So now he has come to the emergency. You recognize that it is 130 heart rate. It was the initial heart rate, and you given him fluid bolus. And what you did for that heart rate? When the BP was stable itself, we could have controlled that. No, why we waited till the BP is going down? What was the reason why we waited? Just inquiring.
Actually, we thought it is hypertension-induced tachycardia.
Hypotension-induced atrial fibrillation unlikely, but our aim is to recognize that tachycardia, and that tachycardia is causing the hypotension. So that is the thing. Here you have to, you thought it is the hypotension that is creating the tachycardia, but it was something because you have given the fluid bolus. Usually when you are removing 500 ml of blood or 350 ml of blood, if you give 1 pint of fluid, and the patient should be otherwise okay. It should not cause hypotension because we have got reasonably good reserve. Like we lost like 1 to 1.5 liters of blood only, we will start developing hypotension. But here just 350 ml, it is a controlled way by which the blood has been taken, and he has been given a fluid also. But you need to keep that in your mind that the hypotension didn't cause the tachycardia caused the hypotension. So this, after that we came to know that because of that heart rate was persistently elevated and the patient went into hypotension. Maybe initially we could have given some rate limiting agents so that the patient would have not gone into hypotension. Okay, so now you waited, you started giving him fluids, but the BP was not improving. Tachycardia, how much was the heart rate again after that?
150.
150. Usually the problem in atrial fibrillation is like it will be usually above 150, 180 to cause these symptoms. But here 130, 140 itself the patient had symptoms. So you went ahead and cardioverted the patient. So again, you selected the drug ketamine, which is one drug that you should not be using here. But why not ketamine? It will again increase the heart rate. It will again increase the heart rate. It will increase the blood pressure. But okay, but there is hypotension. Ketamine preferably avoid in this situation. You can go ahead with any other agents. The safest will be an opioid, will be then midazolam combination. So that is the first thing. And again, the amount of energy selected is also wrong. 100 joules. Whenever you are having atrial fibrillation, you give the maximum possible joule initially itself. So 120 to 200 joules, you go ahead with the 200 joules itself. Otherwise, there is a chance of recurrence to happen. So whenever you are seeing an atrial fibrillation, you try to give the maximum dose initially. When you have supraventricular tachycardia, go ahead with a lower dose. VT, go ahead with lower dose. I would have agreed. But whenever you are having atrial fibrillation, give the maximum joules as early as possible. Like you give 200 joules straight away. Rather than going on an incremental way, you straight away give, even the AHA recommends 120 to 200 joules is the minimum recommendation. So 100 joules is nowhere there. So you have to give minimum of 120, but 200. I will say that you go ahead and give 200 joules directly. So it's a new detected AF, so we are not very concerned about your atrial thrombus formation and all. So straight away went ahead and given the drug. And you said regarding tropi being elevated and you treat it like ACS. Initially, we have to treat it like an ACS because a new onset arrhythmia and you are getting a tropi elevation. But I think there has been some problem with the tropi, because the two reasons why I am saying is that because tropi should not be elevating within 3 hours. It will take 3 to 4 hours to get elevated. So he has an event which just happened 15 minutes inside the hospital premises and tropi point of care getting elevated. That is again the clinician description. We should not, first of all, we should not have sent a tropi during that time. That is my first thing to sell. Initially within 3 to 4 hours don't sell, but again after cardioversion you can have an elevation because of the cardioversion. So you can use the other tools like doing an echo and look for any regional wall motion abnormality. So again it was not a correct thing to do initially. Tropi was not needed initially. Electrolyte, yes, I agree. Any electrolyte abnormality can precipitate, but here he was quite stable enough. He never had any problem. Suddenly there was a withdrawal of the blood that would have triggered, maybe because of the pain, anxiety, we don't know what was the reason, but there should not have been an anxiety. Regularly he was giving blood donation. So such patients coming to the ER like 138, 110, 70 BP. So what would have been your preferred choices during that time?
Metoprolol initially.
You can give any of the drug, calcium channel blocker, or you can give beta blocker, metoprolol or diltiazem initially and control the heart rate, or you can even straight away go ahead and give amiodarone also. So amiodarone also is a very good agent. So 150 mg of amiodarone, then followed by 1 mg per minute for the next 6 hours, then 0.5 for the next 18 hours per minute. That is the next, it's not per kg, it is per minute what you need to consider. So amiodarone also is a very good option, and other agents are digoxin. If there is associated heart failure, you could have gone ahead with digoxin also, but we are not suspecting an heart failure here. So what could have been ideal for this patient, maybe initially a beta blocker therapy, and later on we could have waited, but if not improving, we could have started amiodarone. Cardioversion we could have avoided. We don't know. I am just saying, assuming things. Because when we have given metoprolol, if the rate subsided, there would not have been any hypotension. But that hypotension would have persisted also. We are not sure. We are assuming how better we could have managed this case. Okay. So now the issue is that this patient has 41-year-old. 41-year-old, why he should develop an atrial fibrillation? That's a question. So we have gone through the risk factors. We didn't find anything. The next thing is the structural abnormality, what we need to look in for. So echo.
So echo showing mildly dilated left atrium, no RWMA, good LV, good diastole, good diastolic function. The MR, trivial MR and TR is there with good RV function and normal ejection fraction, sir. No MS. No.
Okay. So there has been some mitral valve pathology for him, which has resulted in a left atrial enlargement. So that might be the reason. That's what I said. Without any structural abnormality, this situation would not have happened. So now, how will you proceed further? So he's stable right now. So how will you further in managing in atrial fibrillation? He's in CCU. Emergency physician rule is over. Once we control the rate, everything is over. But we should know how we need to follow. What are the considerations? We should understand the risk factor, modifiable risk factors. What are the modifiable risk factors? And most importantly, stroke. Prevention of stroke. How we should be preventing an embolic phenomena in this patient. And third option will be rate versus rhythm control. So whether we should concentrate on rate control, whether we concentrate on rhythm control. What is your take on it?
So we should consider rate control in ED first.
So in the ED, you have to consider regarding rate control, but Right now we have got very good drug which can even achieve in the first line agent itself, we can achieve rhythm control also. So previously when we used to discuss regarding atrial fibrillation, we will concern regarding rate control. ED, I am not saying rate control is the key. You need to bring down the rate with giving whatever drug, but we have got better drugs which can bring down the rhythm also as early as possible. So get down the rhythm as well as rate. Previously you used to sell get the rate below 100 or 70, 80, that is acceptable. But now they are more concentrating on rhythm control also. So what are the drugs that you can think it for rhythm control? Amiodarone is a very good agent. It has got side effects. I am not saying it is a very good agent, but it has got its own side effects. What are the common side effects that you need to know?
Hypothyroidism.
Thyroid, hyper and hypothyroidism. In the lung disease, very rarely lung fibrosis can occur. So thyroid, you need to, after initiation of amiodarone, you need to follow up thyroid. But it is a very good drug that it can achieve rhythm control also. So 3 things we need to remember. What are the modifiable risk factor? Stroke prevention, rate and rhythm control. So first thing, risk factors. We have found out what are the risk factors. We are okay. Left atrial enlargement is there. If any alcohol, smoking, all those things, obesity, weight gain, all those things, you should ask them to control it. And the next, obstructive sleep apnea, sleep disorders that can just precipitate atrial fibrillation. So if it is there, you need to ask for a sleep study. So that is the risk factor. Coming to this stroke prevention. So how will you decide, okay, this patient needs this drug or this patient needs some better other drug? So what is the scoring system that you use?
So the charts for scores. It says C is for any congestive heart failure, that will be having a 0.1. H is for hypertension. H is for more than 75 years, that will be carrying a score of 2. Then D is for diabetes. S, which again carries a score of 2, will be for stroke. Then V is for any vascular pathology. A is for again age more than 65 years, that will be carrying a score of 1. And female category, female gender will be containing 1 score. So totally we'll have age more than 72 or stroke, then we'll have a score of 2. And if Charles-Bach score comes more than 2, then patient should be started on anticoagulation for prevention of stroke.
Okay, so other group of patient, what anticoagulation you wanted to start?
We can start on oral anticoagulants.
Oral anticoagulation, you can either start on warfarin or any newer oral anticoagulant. So that is that side, and we can continue monitoring depending upon the target that you want to achieve. So those who have got less risk factors or those who have got high chance of bleeding, so what will you do?
Patients who have been started on oral anticoagulants, we should see Has-Blood score. So that is to be seen for patients who have higher risk of bleeding. That score, sir, states H, Has-Blood stands for H for hypertension, A for abnormal liver or renal function. Each will contain liver function 1 or renal pathology 1. So S for stroke, B for bleeding tendency or predisposition, L for labile INR, one started on warfarin, E for elderly people more than 65 years, and D for drugs, concomitant aspirin or NSAID intake or alcohol consumption. So that will be 1. So total score for the this thing will be 9. Maximum score will be 9. So more than if patient has having more than 3, patient is at more risk
for bleeding.
So these patients, we should continue with oral anticoagulation, but patients monitoring should be done more frequently as compared to the other group.
So what was done for this patient? This factor was how much?
0. So Charles-Bach score was 0.
Was 0. So what was started for him?
He was started only on rate control agents. Metoprolol was started BD, 25 mg, and ecospirin was added for him.
Ecospirin was added for him. So that is only what is required for this patient. Okay. So that is our stroke prevention. So for stroke prevention, he have started him on an ecospirin for his, because the risk factors are less. So we have started on ecospirin, and for rhythm or rate control, you have started on metoprolol, and you have to search for modifiable risk factors. So these are the 3 pillars for the treatment of your atrial fibrillation that you need to keep in your mind. So what happened to this patient? He got admitted.
He got admitted in CCU. He had another episode of AF. So he was started on amiodarone infusion, post which it was reverted. After that, patient was discharged. He was stable, but he was asked to come back for a 72-hour Holter monitoring.
Okay.
That is just to be done.
That has to be done. So he is on metoprolol and discharged. He was not discharged on amiodarone.
No.
He was given an amiodarone infusion, and he was put on a rate limiting drug of metoprolol. So metoprolol, again, it is not a why they will not have started on amiodarone straight away, because of the risk of amiodarone getting into all the toxicity. They would have avoided an amiodarone. But he comes back again with an arrhythmia. He should be put on oral amiodarone. So that will be the best agent for him, because that will have rate and rhythm control as well. You will have rate control with beta blockers, but rhythm control unlikely. But when you put amiodarone, both will be okay. Then You have any other agents that newer drugs, anything that you need to drug for atrial fibrillation? Rate control, these are only the 4-5 drugs that we need to remember. Your dilsum, your verapamil, your metoprolol, even carvedilol can be given, oral can be given if the patient is otherwise stable. These all drugs can be started. Digoxin with failure. These are the commonly used drugs. But what are the other recommended drugs that you can use as IV preparations for the rate control?
So metoprolol, dilsem, sotalol we can use.
Sotalol is another agent.
Sotalol IV 100 milligram can be given. That is 1.5 milligram per hour over 5 minutes. But it is to be avoided if QT prolongation
Is there?
seen.
Okay. Why Sotalol QT prolongation? Why Sotalol QT prolongation? You have to tell me that. Sotalol, when we hear, it is a beta blocker, but it has got a additional sodium channel blockade property also. So that is why we are considering about QTC. So sotalol, when we classically remember, it is a beta blocker. So it's an antiarrhythmic agent with sodium channel blockade also. So when you have a drug that is giving like phenytoin, you are giving sodium channel blockade. QTC prolongation is there. So that is the reason why QTC needed to be monitored. You are not monitoring QTC for your metoprolol. You are not doing why because it's a purely a beta blocker. Sotalol will have both these properties. So that is the main reason. Okay. Then.
Sir, Dornideron we can give.
Dornideron, okay. Instead of amiodarone, we can give Dornideron, but not being used very frequently. 10 years back, it was been coming as an upcoming drug that can be replaced amiodarone. But the problem is that the side effects are less. Maybe the effect is also not comparable as of amiodarone. So still, amiodarone is the first line of agent. Then, okay, okay. Anything else that you want to tell? So what we have understood, it's a first onset of your atrial fibrillation. So previously and all this paroxysmal, this lone AF and all pathology was there, now not being used. So you have to know the technical definitions of atrial fibrillation, and if it's a long-standing atrial fibrillation, what would have been the difference of your management? This fellow has been having atrial fibrillation for more than 2 weeks. So what would have been the difference? What you would have done for this patient? Long-standing atrial fibrillation. It is not a permanent AF. You remember that it's having a permanent AF. He has come with a heart rate of 140, 180 to your ED and with hypotension. What you would have done? What is the problem? LA clot, one important. Transesophageal echo is one of the important things. Yeah, it's a chronic atrial fibrillation. You have to rule out an LA clot by doing a transesophageal echo and heparinize him, and then you shock the patient. So it should be a planned procedure. So you cannot just go ahead and jump. But again, with hypotension, it's a big challenge. You need to see the risk versus advantage, whatever he's having. Maybe you can, even if there is hypotension, you can try amiodarone. You can give a time amiodarone, try to bring down the heart rate. But I am saying it is a different scenario. Chronic atrial fibrillation, you need to rule out an LA clot. So that is very important that you need to keep in your mind. So atrial fibrillation, remember, as an ED physician, is to recognize the atrial fibrillation, and idea will be rate control initially, but always consider rhythm control is also very important in atrial fibrillation. And 3 things is the pillar of therapy: stroke risk, modifiable risk factors, and your rate and rhythm control. Okay, fine. Thank you.